I can get started with the meeting here then. Welcome everybody. My name is Bruce Holmblad. I'm the Riverside County Medical Association president. And once again, this is our bi-weekly call that we have with Dr. Cameron Kaiser. If you don't already know, he's our Riverside County Public Health Officer that has performed magnificently during this pandemic crisis. I know that myself and my family are very grateful for all that Dr. Kaiser has done to help keep myself safe and my family safe. Just a little housekeeping. If you have any extra questions besides the 9 questions that Dr. Kaiser will be answering tonight, please put it in the chat box, and if we have enough time, we'll try and get to those questions that you pose in the chat box. And without further ado, Dr. Kaiser, if you could give an overview on the state of the county, and then we'll go on to the questions.
Thank you, Dr. Holmblad. As most of you are aware, Riverside, like much of California in general and multiple areas in the United States, is currently experiencing a recent increase in COVID-19 cases, which we primarily attribute to people being, frankly, just out and about. Currently, we have 15,142 cumulative cases, 311 hospitalizations, 95 of which are in the ICU, 435 total deaths, and our recovered number is 7,272, which means that over half of our cumulative case burden is still considered active right now, and at least some number of them are potentially communicable. This is quite an alarming spike in hospitalizations for the summer. In fact, our hospital numbers currently are the highest that they have been during the pandemic. And I note that there is a large submarine number of COVID pending patients in house, I should say. And some of those will almost certainly be positive as well. A few misconceptions I'd like to meet head on. The major driver is not Imperial County, despite what some reports have said. We are taking single digits of those patients, and they are not in large numbers. Our EMS agency is monitoring that closely. We, of course, do have certain mutual aid responsibilities, and we would expect the same of them. But Imperial County patients are actually being distributed widely throughout the state. We are not the major one receiving them, even that actually is San Diego. Similarly, only some of those numbers can be attributed to the large outbreak in Chuckawalla State Prison because only small numbers of those people have been hospitalized, although some of the CIM and CIW cases are here due to contractual obligations. Overall, and this is also a general trend, cases are skewing younger right now. And this leads us to attribute it in some amount to the protests, but also to the general opening of the economy, because frankly, that's the people who are most likely to participate in it. These folks are less likely to be admitted, and they are, of course, much less likely to die, but they can certainly be symptomatic. And we have ground evidence that they are being seen more frequently in EDs, urgent cares, and same-day clinics. They are not usually being admitted, but this is yet another reason why the face covering mandate is so critical, because they are almost certainly communicable. I would like to thank the RCMA and CMA for their support of public health officers, since at least in California, we are physicians too. The statewide facial covering order unfortunately came too late to save Dr. Quick in Orange County, but we do believe that this is at least in some way helping to blunt some of the rises we're seeing now. Because of the continued departure of health officials nationally, I am now pinch hitting for the HHS Region 9 seat for the National Association of City and County Health Officials, because we have multiple national board vacancies throughout the United States. The long-term forecast for COVID-19 continues to be murky with the absence of generally acceptable treatments or vaccines. Frankly, I would have been surprised if dexamethasone didn't do anything. Fortunately, the press has learned from their previous hasty pronouncement of magic bullets. But my guess is if we're seeing this much activity right now, we will probably continue to see regular new cases all the way through the rest of the summer. And this frankly portends very poorly for the fall. It's not really going to be a second wave per se, just a really big and lengthy first one. We are hearing that flu vaccine manufacturers are increasing their production targets by around 10% from last year in order to meet what is likely to be significant demand. And I really hope that demand materializes and people get them, because if we have a bad flu season this year on top of persistent COVID-19 infections, then we are going to be in for a wild ride in the winter. With that, Dr. Holmblatt, I will hand it back over to you.
Thank you very much, Dr. Kaiser. So our first question, with the opening of Riverside County, there has been a rise in COVID-19 positive cases. What is the current rate of doubling of positive cases right now compared to the peak in April?
Today's 3-day average is about 27.3 days. Actually, our high on doubling rate was about 33 days around the second week of June. Now, that number might seem long, but it's actually rather worse than it sounds. And you're hearing less said about doubling rate now because, frankly, it's much easier to go from 1 to 2 than from 10,000 to 20,000. Even today, we added 237 new cases. We added 631 just 2 days ago. So even though the doubling rate appears deceptively high, I think that's an artifact of our large cumulative numbers in general. We are still adding cases, and in some cases we are adding them at a very rapid clip.
Okay. Question number 2. Riverside County is on the state's watch list. What does that mean, and what are the implications?
The state has 3 specific metrics that it evaluates counties on. The first one is disease transmission. Counties get flagged if they have a case rate greater than 100 per 100,000, or if it's greater than 25 per 100,000 and a test positivity rate of greater than 8%. We fail both metrics, in fact, because we have a case rate of 141 per 100,000, and our most recent positivity rate, which is to say the number of positives in the tests which we are running, is about 10.6%. The second is the percent change in COVID-19 positive hospitalized patients if it is over 3 days greater than 10%. Notice that that's sort of an odd measure. It's not really a rolling average. They're taking it as 3-day blocks. We're not sure why they're doing that, but that is the methodology they have chosen. We fail this benchmark intermittently. Right now it's about 5.4%, but again, I note that our hospitalization numbers are quite high already, so I would not read that necessarily as a determination of the impact on the hospitalization system as a whole. We certainly have some rocks at some of the hospitals. And again, as I mentioned, our hospitalization rate due to COVID-19 is actually the highest that we have seen to date. Finally, the state also flags counties which have fewer than 20% of available ICU beds and fewer than 25% of ventilators available. We are currently okay on both of those metrics, but I do note that we're moving people from the floor to the ICU, so we are watching those numbers because they do shift around somewhat. To give you a local perspective, San Bernardino, for the record, is failing both transmission and hospitalization benchmarks right now, so this phenomenon is hardly unique to us. Because of the current trajectory and the way the standards are written, we're probably going to be failing one or more of those benchmarks for some extended period of time. The problem is we do not really know what the implications are. Governor Newsom, in his news conference yesterday, made it quite clear that the state will withhold realignment money from counties which are not following the statewide orders. He has made public statements as well that the state will not go backwards on reopening, but many of our sectors which are currently open are based on the fact that we have a stage 2 variance. The state can withdraw this variance at any time, which means those sectors will no longer have permission to operate. That variance is always at the pleasure of the state, and that is probably the easiest thing they can do if they want sectors to shut down in a hurry. The state may also require us or impose on us additional closures or special conditions, but they have not clearly delineated what those might be. You will also probably have noticed that after several straight weeks of guidance drops for specific business sectors, there was no new sector guidance announced for this week. This is not a coincidence. It is by no means specific to counties on the list, but it is certainly planned. Just an hour ago, we were on a statewide call with Secretary Mark Ghali, and he said explicitly that there will be no specific guidance coming out, and in particular on gatherings, which is a message that we should understand to mean they will not be permitted in the near term, including the so-called social bubbles and extended family gatherings. The state is not issuing those guidances because they do not want people to do them.
Okay, thank you. Question number 3, what is the status of the field hospitals? Were they closed or are they still operating? If they are closed, what plans are being made to reopen in preparation for a second surge of cases?
By the field hospitals, I assume the questioner meant the federal medical stations. We received one full FMS. This can serve 250 patients for 3 days out of the box, and it comes in a lot of boxes, which we split into two 125-bed units. These half units are still deployed, and they are still ready for action. The only thing that we lack is staff. One of them is at the old Sears building off Arlington here in Riverside, and then the other is at the Indio County Fairgrounds. Now, I stress that the surge plan would involve a lot more than simply activating those FMSs. We would obviously make every effort to do interfacility transfers instead or invoke mutual aid before we got to that point. However, they are an important part of our decompression plans. We do have a full procedures manual. I know because I wrote about 90% of it. And we can staff them quickly if we do need to get them up, both through the state volunteers, but primarily through our local volunteers program as well. At this time, there is no plan to return those FMSs to HHS. They will be staying where they are for the foreseeable future, although what we can actually foresee in the future, of course, seems to be getting shorter all the time.
Okay, thank you. Question number 4. We are hearing that the hospitals are seeing increasing number of COVID-19 patients. Is Riverside County monitoring ICU bed capacity? And is this the case throughout the county or only certain hospitals? What are the plans?
Most county hospitals are seeing an increase, but the hardest hit again has been the Coachella Valley, much as at the beginning. People have taken this as an indication that heat doesn't really seem to affect the virus all that much, and that might be true. Although a glass half empty view would wonder how bad it would be if it was actually winter right now. REMSA does get daily bed totals of full censuses and COVID-19 censuses for both ICU and med-surg. We are working with HASC on a collaborative county-wide surge plan. We had this in early form for the large hospitals during the initial phase of the pandemic. We are putting the pieces together to get all of the acute care hospitals on board in case we get a double whammy in the fall. But we are monitoring a county-wide increase in all of them. Desert physicians, of course, should be particularly aware of that because I would say that's probably where our greatest increases are occurring, at least right now.
Okay, thank you. Question number 5. My wife is a teacher with Corona Norco Unified School District and has been told that all classes will start in August in the usual fashion. Full classes every day like normal. Word is the board was under tremendous pressure from the parents to bring kids back to campus, not only for their education, but for childcare issues as well. Are you going to provide guidance / requirements for class size and other issues for public schools in the county?
Not only am I going to do so, but actually I already did. In addition to the CDPH and CDE guidance, RCOE has a joint document that the county superintendent, Judy White, and myself have both signed off on. Now note that there is only so much control that RCOE or myself has over the individual districts. And while I can certainly order schools to close, I will simply say for the record that the Board of Supervisors would prefer that the districts align and work with the state, and all of the guidances are guidelines which are recommended but non-normative. I do, however, continue to recommend that all of them do the maximum that they can do, but the biggest issues currently are indeed class size, facial coverings, and social distancing, especially with regard to busing and transportation. Now, some aspects of this are certainly district specific, and of course the teachers union has their own ideas about them as well. The class size issue is being dealt with through distant learning policies appropriate to age and as well as staggered schedules and certain other mitigations. But facial covering and social distancing policies currently vary quite widely. And I think all of us realize that one policy cannot hope to cover all age ranges. I will say for the record that we do periodically reevaluate the school numbers. And as I've mentioned on other calls, it seems pretty clear that kids get COVID-19 at about the same rate as everybody else. And as proof of that, I in fact got the most recent report today, and their positivity rate has been increasing right along just as we've been expecting in the general population.
All right, thank you. Question number 6. Restaurants and bars are packed with people and not observing the mask requirements and social distancing. What is the plan to monitor this, and what are the ramifications to these establishments?
This is, I'm going to tread delicately on this question. This is where the law enforcement side comes in. We are talking with the sheriff and with other county departments to see how we can improve compliance. I am certainly 100% agreed that at least some part, in fact, probably even the majority of the increased community spread is attributable to that very phenomenon. More than that, I probably can't say right now.
Okay. Question number 7. Are we expecting more remdesivir doses for Riverside County? And if so, would you please review the process that is used for determining how the doses are distributed?
The answer is yes. In fact, I signed off on the distribution of another 1,200 odd doses yesterday, and we expect to continue getting doses every couple of weeks, at least until the national HHS allotment runs out. This process is based on current COVID-19 positive censuses. As I mentioned, we get these daily, with ICU patients counting 2 for 1. We do not include facilities marked as clean, i.e. for those in a multi-hospital system where they have designated one hospital to receive all of those. The other facility, naturally, we don't send any to them. And then Kaiser also has a collective disbursement since they are one system covering 2 hospitals. But otherwise, the distribution is directly based on what COVID-19 cases hospitals have in-house and their acuities. This isn't secret information, and we certainly do give it out to people who are interested, but it isn't something I think is a good idea to regularly publish publicly, because once you know the methodology, you can easily infer which hospitals are being hit the hardest, and I imagine the hospitals would not be happy about that information being widely distributed. But we do try to have as equitable an arrangement about how remdesivir gets out to the hospitals as possible. We try very hard to also make sure you get a full 6-dose, 5-course or 6-dose, 5-day aliquot series so that you can use a complete course for as many patients as possible. But we also want to be mindful of the fact that given that we dose this according to hospital acuity, this obviously is a source of information which could be damaging in the wrong hands.
Okay. Question number 8, with the increasing COVID infections in our community, our hospitals, LTC facility admissions, visits to the EDs, urgent care centers and private offices, etc., this will expand the need for PPE. Is the county continuing to secure enough PPE? And if so, what is their current inventory looking like? Private offices continue to do our best to secure PPEs, but there are ongoing challenges, especially if numbers continue to grow. What would you suggest? What do you suggest?
I checked with the emergency management department earlier today. They are still continuing PPE buys and servicing hospitals and offices as priority and capacity permit them to. Now, again, unfortunately, there is still no magic bullet. It is still catch as catch can for what is out there. I know RCMA has done some PPE buys. IEHP has done some as well. As I've said before, and I'll repeat today, if you understand the mutual aid nature of the MOAC, that's the Medical Health Operational Area Coordination Program, and know that you may be asked to put into the system if you have extra, you are still welcome to email mhresource, that's the letter M, H, resource, @rivco.org with a detailed request for PPE for your facility. Remember that outpatient facilities are Tier 2, inpatient acute care is Tier 1, first providers as well, but we are still servicing outpatient facilities on a first-come, first-served basis as availability allows, and I confirm that we are still doing so today.
Okay. Question number 9, what are you most concerned with right now regarding COVID-19?
Well, golly, where do I start? But I think I'd have to say that I have significant pediatric concerns, given that we really have no data on the long-term outlook for kids who get infected. And also, as our cases right now are skewing younger, we don't know the long-term outlook for them either. We only know that they are less likely to be hospitalized and certainly much less likely to die. But I don't think enough people have really been followed long enough to understand if there are other long-term complications as a result. But if I had to pick one thing, I think I'd be most concerned about how politicized every little bit of data has gotten by now. Not only are people disputing test results and their clinical relevance, and including that on death statistics, but now actually people are starting to attack hospitalization data, and people are coming up really with every contrived situation they can think of to cast doubt on those numbers as well. I got asked yesterday about the hypothetical situation of somebody being admitted for an elective procedure who tested positive. And they said, well, wouldn't that count as a COVID-19 positive hospitalization? Yeah, I said it probably would, but I also wouldn't expect them to be there very long if they weren't having symptoms. So it really shouldn't affect them much. And many same-day surgeries wouldn't be admissions in the first place anyway. On top of all that, we've had bogus reports of helicopters bringing in patients all the time from Imperial County and across the border, and those things are just a lie. The personal security issues that I and other health officers have been confronting are really just an issue or a symptom of the larger problem. That people aren't taking this seriously. They want to do what they want to do, and they don't care that it's actually materially imperiling the medically fragile. And it's really hard to struggle against that and tell people to do better, who just want to go to movies and go out to eat and shop and doing all the things that continue to really mix COVID-19 in large numbers into the population. What we're seeing right now is we are reaping what we're sowing, and it's only getting worse. If we estimate that it may take a little while for a case of COVID-19 to be severe enough to hit the hospital, then we're probably going to be seeing more of it as we look forward. As I mentioned, we have this submarine number of COVID-19 pending patients, which I expect some measure of. If I've got a 10% positivity rate out there, and I expect it to be higher for people who are symptomatic, easily 1 out of 5 or more of those are going to move into the hospitalization pool, and some of those will end up in the ICU as well. And we're seeing this in June. I shouldn't be seeing numbers like this in June for those kinds of things. Long and short of it is, I think there's a lot of things to be concerned about, but what I'm most concerned about the fact is that we're going the wrong number, we're on the wrong direction on things. We're seeing our numbers going up, and I think that people believe that this is a minor infection, and for some of them it will be, but for some others it will literally mean the difference between life and death, and the more we have it out there, the more people are going to be put in that position.
Okay, thank you very much. Do you have time to answer a few questions out of the chat box?
Yes, although I don't see any.
Dr. Kaiser, there was one that actually came in late this afternoon that is being asked again, and that is in regards to the one we had asked if one of our medical assistants had tested positive with COVID-19. As a pediatric office, what are we supposed to do? We heard one practice had to close for 2 weeks when one employee was exposed to a friend that tested positive.
The legal mandate is you have to notify us about that case. As far as whether you're required to close or not, that's a different story, and that may be something you decide would be appropriate based on how many people in the office may be exposed. If there's a large number of people being quarantined as a result, then you may not much have choice because you just won't have enough staff around to keep the office open. We would do that on a play-it-by-ear basis. But the first and most important thing that you should do is call it in. I asked the folks upstairs what number they want us to call that into. We did have a hotline, but that one is getting impacted. So I would say at least temporarily, please run these through the disease control switchboard. That number, which most of you are familiar with, is 951-358-5107. And I'll repeat that number. 951-358-5107. That number is open during business hours. Unless it is an emergency, I'd appreciate you waiting until the next day to call that in because our on-call staff are, of course, getting besieged at the moment. But if you do have an office exposure like that, we can help. Just be aware, though, that even though you don't necessarily have to close as a legal requirement, you may need to close as a practical requirement if it turns out that we end up quarantining a large number of your staff, depending on the nature and the the proximity of the exposures.
And Dr. Kaiser, do you want to talk about the protocol that we have posted at the bottom of this document?
Yeah, this is the basic protocol that we would be using to enable healthcare workers to be cleared, which would include your staff. Healthcare workers under the governor's executive order are allowed to work as long as they are asymptomatic. And that's why I said if you end up having a large number of staff who actually are sick, that may well close your office, because at that point we would not allow them to work. If they are asymptomatic, we're working on a way that we can get them back to work through a fast track. They would have to wear a mask, but frankly, everybody has to be wearing a mask now anyhow. For symptomatic individuals, however, please let us clear them. Even though the general principle is 10 days, and we're a little more stringent than the CDC non-test criteria. The CDC says 10 days since the onset of symptoms, but some people will not have any symptoms and they may not have it for a while. So we've gone from 10 days since the date of the test. And then 72 hours either asymptomatic or with full resolution of fever and substantial resolution in respiratory symptoms. You are, of course, welcome to be more restrictive than that, but please do not clear patients with, or do not clear staff without talking to us first. We can assist you with this, but obviously you'd probably not want them back to work in that case anyway. Another question we've gotten is, do those folks need to be tested again? The answer is not necessarily. We have not been requiring that of the majority of people we have cleared, including healthcare workers. As far as I'm concerned, I don't test people after they have the flu. If they're well, you go back to work. I don't see any reason to treat this any differently. But again, in your office, if you believe it is a high-risk situation and you want to demand that they be tested, you are perfectly welcome to do so. That would be the responsibility of your office if you did make that requirement. And do note that because of the nature of this, they are likely to be shedding junk virus for several weeks.
And then another question that came in, that didn't get on this list was, reopening has become very confusing. There are White House criteria, CDC, state, county, municipalities. What are the hard measurable criteria we should go by? For example, R value, 150 new tests a day per 100,000 population, et cetera.
Strictly speaking, physician offices were never closed by anybody. This is going to be a decision based on your individual practice and what you think is appropriate for operating, but they were always considered an essential service, even when we had that distinction. As far as I'm concerned, the real question to you is whether this is appropriate for your patient mix. Whatever you end up doing, though, the guidelines that you should be following as a procedural aspect of your practice should be those based on CDPH. CDPH on its covid19.ca.gov site and also on the main CDPH site have specific guidances for healthcare workers. And I think, Dolores, you linked to those already. And these are specific guidances for what you really should be doing in your practice to have it open. But as far as the decision to actually open it, I never closed you officially. Just make the determination based on what you think is appropriate for your practice. And, there was a question that went on, should we consider every potential patient who walks through the door to be COVID-19 positive? Well, if I've got a 10.9% positivity rate in my population, you can assume at least 1 out of every 10 will be, assuming that number is at all statistically representative. Therefore, you should take appropriate precautions. And I said one of the middle ground approaches that I've taken, at least personally, is you need to be wearing a surgical mask with every patient. But for a symptomatic patient, you may want to be using an N95, or if you have the ability to have negative pressure, using that. Obviously, I work in a TB clinic, so that's fairly easy for me to accomplish. But all the patients that come in, regardless of their symptomatology, should be wearing some sort of face covering, and I would make sure that you wear a surgical mask with each and every one of them as a minimum. I'll answer a couple questions which just popped in, although I am also getting paged by the executive office, so I'm going to need to get off this call pretty quickly. I'll try to answer the 3 questions that I have up. Will the CalCat measures be most useful? Maybe. The CalCat just came out today. For those of you who are unaware of it, the state is doing a a statistics dashboard where they're computing a effective number of transmission, and they are also trying to do hospitalization forecasts. The answer to the question is the REFF number that they compute. We've actually been doing this internally ourselves with the department. I haven't released these numbers because we've been trying to work through methodology notes, but the numbers the state are getting are broadly compatible with mine. So if they agree with me, then they must be right. But you know, jokes aside, we're getting much of the same figures. So these are probably the effective reproduction number is probably, I would consider that to be probably a robust figure. Our current number is somewhere around 1.06. Remember that the number 1 means that the infections are essentially self-sustaining at a 1-to-1 level. It's the number of cases you can expect to occur for every single case. 1.06 then means that we will slowly continue to increase as we have been doing. But remember, with approximately 8,000 active cases right now, that means we'll probably, you know, continue to move to other cases at a rate of about 106% of that number, at least for the moment. Any recommendations for Coachella Valley? I would say for Coachella Valley, please stick with what you're doing already right now. Even though Coachella Valley numbers are certainly worse than the rest of the county, the rest of the county is still pretty lousy, and I will continue to take precautions no matter what circumstance you happen to be working in. The last question that I'll do, and then I really do have to get off. Why is there back and forth on the use of masks, and what should be the recommendation regarding kids at school with masks? The statewide call I literally had an hour ago brought up that very interesting question. Now, as far as the back and forth on the use of masks for adults, there's no more back and forth. There is a statewide order and people need to follow it. There's been some argument about, well, the governor kind of made it his guidance, so he didn't really say you have to. The governor said must, and our county council interprets that as an order. And I always listen to what my lawyer tells me. So that's the recommendation I'm going to make. And as far as there was some question before, there was an injunction apparently in one county. That injunction, as far as I'm aware, was overturned. The governor absolutely has the ability to do so in case your patients happen to tell you differently. As far as the recommendation about kids with face coverings, though, there is some going back and forth on this. I think we're agreed that the use of face coverings needs to be age appropriate, and the governor's masking order does not require kids under 2 to wear them. Of course, school-age children are greater than an age level. But there's also some evidence to suggest that even young children can comply relatively well with them as long as it's something that's not ill-fitting and that they're able to handle. So you will see a plethora of opinions from districts based on, frankly, what parents end up telling them at board meetings. And there is no hard and fast recommendations on this at any level, including nationally. But at least for some population of kids, they really seem to be able to do it. And certainly the older they are, the more able they are to do so. I think we should continue to encourage schools to do what they can and kids to be able to do so what they can. Inject whatever measure of self-expression or whatever into that can be done to make the wearing of a mask, you know, at least as fun as it can be. And I continue to recommend to the schools that they do so. If they're in a situation where we're busing them and we really can't maintain social distancing, it's going to be almost a must. But as far as kids go, we're recommending they do so in whatever circumstances are appropriate for them. But for adults, there is no more back and forth. It should be everybody. With that,
no,
I have to go off, so.
Yeah. Dr. Kaiser, thank you very much for your time. Once again, we'll talk in 2 weeks. Thank you very much.
You're very welcome. I'll talk to you then.
Thanks. Good night, everybody.
Thank you.